Our next speaker is Grant Sara. Grant is Systems Information Director at the New South Wales Ministry of Health, and he's the Principal Investigator for the New South Wales Mental Health Living Longer Data Linkage Project. And Grant's going to talk to us about vaccine-preventable hospitalisation in mental health consumers. Is a booster needed?
Thank you. And in the spirit of informed consent, I should let you know I'm the next speaker as well because Chris is unable to join us. So apologies, you're about to hear two presentations back to back. Hopefully the content will be relevant. So I just would like to start by acknowledging the Yugambeh and Kombumerri people on whose lands we meet, and also acknowledging that we're looking at data today from people who've used New South Wales hospital and community mental health services, and we use their data with gratitude and respect, and certainly with the goal of trying to improve care for those people. COVID has certainly been a pretty vivid reminder of the importance of vaccine-preventable conditions as a cause of illness, as a cause of premature death. But despite that, the evidence about the vaccine-preventable conditions in people living with mental health conditions is actually quite limited. There's quite a lot of studies have looked at hepatitis, but when we look at more broadly vaccine-preventable conditions and respiratory conditions, the evidence is reasonably modest. There's a handful of studies that have looked at lower vaccination rates, higher hospitalisation rates, and we did some work a couple of years ago looking at overall preventable hospital admissions, and one of the findings that really struck us was very high rates of vaccine-preventable admissions, which wasn't really our initial focus in doing that work. So this work that I'm presenting today is an extension of that work, looking at 5 years of data, so we can look in a bit more detail and drill in and try and look at individual vaccine-preventable conditions. So this is part of the Mental Health Living Longer data linkage project. So it's an ongoing 6-monthly linkage of data being done by the New South Wales Ministry of Health with the goal of trying to help support policy and service improvement to reduce mortality in people living with mental health conditions. And in this study, we're primarily looking at admitted patient care and community mental health care. What we've done is looked at all hospitalisations to New South Wales public and private hospitals over a 5-year period from 2015, and we're looking at adults in this study. And we identified vaccine-preventable hospitalisations using definitions from the Australian Commission on Quality and Safety in Healthcare, and identified about 100,000 admissions of that type. And then we've divided those into, depending on whether people have had recent mental health care or not. So by mental health care, we mean any public or private hospital admission for a mental health problem or to a mental health unit, and any contact with one of our public mental health services. We don't have data, unfortunately, on primary care or private specialist care or NGO care and support. So we're really looking at public and private hospitals and the public community mental health teams. And we identified about 300,000 people in that age group, in that group. By recent mental health care, we mean care in the 5 years of the study or in the 2 years before as a look-back period. And we limited we defined mental health care as being the time after your first mental health contact. So if people, the time people were in the study but before their first mental health contact and any hospital admissions, then we've counted in the no mental health care group. And the statistical comparison, comparing the rates in the two groups, after standardising for broad age groups and with some other exclusions we can come back to. And here's what we found is that people with who had used mental health services had 4 times the rate of vaccine-preventable hospitalisations per capita as the rest of the New South Wales population. So around 1,200 per person per 100,000 person years, as opposed to about 300. So substantially more. Now, people who use mental health services are younger than the New South Wales population. So once we adjust for those age differences, that further emphasises the difference in vaccine-preventable admissions. So the adjusted rate ratio, that AIR there, is closer to 5, so nearly 5-fold. If we drill in one level and look at, well, what type of vaccine-preventable conditions are we talking about, that we grouped them into 4 broad groups, and the 2 most common groups were respiratory infections and hepatitis B. And there's a very small number of other conditions, and I'll show the details of those in a second. But you can see that in all of the groups, the pattern was much the same, and the adjusted rate ratios in the pink boxes there are all markedly raised. So the highest was for hepatitis at 5.6-fold, but for all of them, it was really 3 to 4-fold or above. If we drill in another level, these are the individual diseases that we looked for, and you can see there's quite a few in those 4 groups. The first thing to point out is really that well over 90% of the admissions were 3 conditions: influenza, Haemophilus pneumonia, and chronic hepatitis B. And for a lot of other conditions, thankfully, there were very few admissions, and for some of those conditions, we weren't able to calculate a rate or a rate ratio because the numbers were too small. But wherever we could calculate a rate ratio, the picture is pretty consistent that across all of the illnesses that we could examine. So if we're trying to support improvement and target activity, then we want to know about both absolute risk and relative risk. We want to know who's got the highest rates, but also where are the biggest gaps. And so what we're looking at here is we've got the absolute risk, the rates here in the vertical axis, for the 4 broad age groups that we looked at. And then the relative risk is the pink number above, that adjusted rate ratio. So you can see that, and we're seeing the mental health service users are in the blue line and the rest of the population in the grey line. And so you can see that vaccine-preventable hospitalisations increase steeply with age, but much more steeply in people who use mental health services. That the gap is there in all age groups, and there's not big gender differences, slightly more in male than female. The biggest relative risk, though, the biggest compared to their own age group, was in younger men, where the risk was around 7-fold. If we looked at those 2 broad groups, the pattern for respiratory illness was pretty much the same, but for hepatitis it was different. The highest rates of admission for hepatitis were in people in their 40s to 60s, and the highest relative risk particularly was in younger men in their 20s, with more than 10-fold risk of increased risk of admission. So that's showing substantially high rates. We wanted to look a bit further because there could be other explanations for at least some of those differences to do with other factors that could be associated with vaccine-preventable hospitalisation. So this is, and probably the best place to focus here in the first is just this panel. So this is a regression where we're looking at, if we just take everyone admitted for a vaccine-preventable hospitalisation, and we look at, well, how did people with mental health conditions in that group differ to the rest of the New South Wales population? So you're seeing odds ratios here. If they're pointing to the right, that means it's more likely. Pointing to the left, that means it's less likely than the New South Wales population to be in that category. So what it's showing is that amongst people who had a vaccine-preventable hospitalisation, mental health service users were much more likely to be male, much more likely to be under 65, and nearly 3 times as likely to be in their 20s. Much less likely to be born overseas, so much more likely to be born in Australia, and much more likely to have comorbid medical conditions. So this is a measure called the Charlson Comorbidity Index, which counts the number of other conditions that people have. This finding around country of birth is particularly because of hepatitis, and it's really because there are geographical differences in who gets hepatitis B, related sometimes to childhood exposures. The other thing we could see in this statistical approach is that those differences aren't just because people are living in more disadvantaged areas or more rural areas. There really wasn't a strong pattern associated with any of those things. So, so that's pretty clear there. So zooming back out again, I guess just to look at those overall numbers, it's worth underlining just that the personal and system impacts of these are potentially quite considerable. So we found that in the broader population, 1.5% of the population had a vaccine-preventable hospital admission during the study, whereas for people who'd had contact with mental health services, it was 6%. Not only were people more likely to have an admission, they're more likely to have multiple admissions, 1.7 admissions per person rather than 1.4, and they stayed longer in hospital as well. So those things combined meant that people with recent mental health care in this study were about 3% of the population, but they experienced about 12% of the vaccine-preventable hospital admissions and about 13% of the vaccine-preventable bed days. That was pretty similar across all of the all of the condition types, but I'll just point out the bottom one there, which is influenza. So we're used to that idea every winter of the impact that influenza hospitalisations have on our hospital systems and healthcare systems. So in this data, 11%, so over 10% of the influenza bed days in New South Wales hospitals were due to, or experienced by, would be a better way of putting it, people who had recent mental health contact. So just to finish up with two slides. So first is really, we should stand back and think about, well, what's the mechanism here? What's going on? I mean, it's tempting to jump straight to the obvious explanation that it's about less vaccination, and that almost certainly is part of it. But when we're looking at vaccination and vaccine-preventable illness through the lens of hospitalisation, what we're really looking at is severe illness. We're looking at people who've had an illness that's severe enough, influenza say, to end up in hospital. And so there could be a number of things that lead to people having a more severe illness. It might be that they've got other underlying risk factors. They might be more exposed to illness. They might be less likely to be vaccinated. They might therefore be more likely to get the illness and then to get more severe illness. So in this data, it doesn't look to us like some broad covariates like disadvantage or rural location aren't the major drivers. It's possible that some young people with mental health conditions, for example, might be living or working or studying in situations where they're more likely to be exposed to influenza or other conditions. It's obviously very likely that low vaccination rates are contributing here. There is evidence for low vaccination rates, which would lead to higher rates of illness. But we think it's also important that in this data there is evidence too that it's not just about lower vaccinations. It's also about higher comorbidity, meaning you're more likely to get severe illness when you do become unwell. So one of the reasons we wanted to focus on this is because this is an area where it's possible to act. Vaccines work, and as we've seen in COVID, it's possible with effort to improve vaccination rates. So, but clearly, there's no one strategy. Like everything else in Equally Well, it's really about tackling a whole range of different, complex interactions. But I think, you would argue, I think, based on this kind of data and the other evidence, that these are some of the areas we could act. So the first is about hepatitis B. So my clinical experience has mainly been in early psychosis services with younger people. And I think it's fair to say we didn't really have a big focus on hepatitis B. I think we should have. We should be really thinking of, really promoting vaccination as a really important priority in young people seeing our mental health services. For our adult and older persons' mental health services, we should really be thinking about promoting vaccination and also thinking about that high-risk people aren't just people who are over 65 or over 75, but that potentially all consumers, you could see that higher rate of increase even in people in their 40s. So we should be thinking potentially about anyone who's living with a mental health condition and over 40 as being at high risk and needing to support to be able to access vaccination if they chose to, but also anyone with comorbidity who's younger than that. We know that just telling people to get vaccinated isn't, it has some effect, but we need to address the many health systems factors that contribute to these kind of issues. And some of those are about relationships, trust, stigma. Some of them are about health system structures, and some of the technical things, including things about data. And I think those findings about comorbidity underline just the connection between this specific type of work and the broader issues about Equally Well, is that even if people aren't vaccinated or they are vaccinated and become unwell, if their general health, their respiratory health is better, then they're less likely to have a severe illness and end up in hospital. We're really keen to keep going with this work from an analysis point of view, as well as trying to gather more data. We know that we don't have data on some other important covariates that we would love to have and we don't currently have. We are working at the moment on routine linkage of New South Wales health data with vaccination data, so we can start to feed back to services and encourage vaccination rates for COVID initially, and also looking at implementing a key performance indicator for our local health districts about vaccine preventable and other preventable hospitalisations that could be reported back as part of that structural helping create the awareness and incentives at the organisational level. So look, I'll stop there and I'll just acknowledge our team working on mental health living longer and our co-investigators and particularly our colleagues at Uni New South Wales who have been doing a lot of work on vaccine preventable work as well. So.
Thanks, Grant. Join with me. Do anyone have any questions for Grant for this? Yeah, Andrew.
Thanks, Grant. Great presentation as always. I think the arguments for the health reasons for vaccinating vulnerable populations like those with severe mental illness are really obvious from the
Yes.
data. Just wondered whether there were any plans by your group and other groups to do an economic analysis on this as well, to kind of, I guess to convince the bureaucrats that it's worth investing in?
It is a good question. I mean, we don't have, health economists in our team. I mean, we are definitely those issues of, even just sort of crude analysis of bed days and preventable bed days there, it provides a pretty strong argument. Look, our experience in presenting some of this data is that the bureaucrats, who I have to confess I'm one these days too, don't need a lot of convincing. I think the data is so compelling, the higher risks, the number of bed days. But yes, look, it would be interesting because there's the bed day costs are easy to calculate. I guess it's the costs for individuals of, chronic illness, disability, and so on that, would need that kind of thing. But yeah, I'd be interested to pursue that for sure.
Any other questions for Grant?
Just quickly, have you ever thought of looking at vaccine preventable cancers? Or is that too hard?
Look, it's a good question. We have wondered, we're just doing some work on cervical cancer screening at the moment. There's an issue about the recency of that as a program and also the time lags before you can show the effect, I guess. So, look, very relevant issue, yeah. I think probably the best place to start would be to look at vaccination rates, rather than, before we could get to outcomes, yeah.
Do you think that any flexibility in the upcoming called national immunisation schedule might help so that if you've got a patient with a doctor and the patient's willing to have a vaccine and the doctor's willing to give it to them, that those sort of population guidelines don't get in the way in terms of the cost of it, and you might be the wrong age, you might have missed out. Is there scope?
Yeah, look, absolutely, and it probably does relate back to Andrew's question as well in a way. Look, we have been talking to Patrick Gould and Phil Ward at Uni New South Wales, and they've done some really detailed, they've got a much more detailed understanding than I do of some of those cost barriers and exactly where they work, and I definitely think we're...
Vaccine preventable things about $175 of cost per day even free vaccines.
Yeah. So look, yeah, absolutely, it would be our intent to try and marshal some of this in a way that we can then identify where are there those bureaucratic barriers that can be changed, and, some of those cost barriers and making sure that people are eligible. Absolutely would love to go there. Yep.
Just a tweeted comment that's come through. It said, when you put it that way, I think everyone should get vaccinated, and that's by someone named Pete Evans.
Yeah. Thanks, Pete.
Yeah.
Love your work.
Absolutely. Thanks, Grant. There's no more question. I think this is fascinating. When do you think they're going to, any timeline for when the COVID data will be available for you?
Look, we are hoping to be able to start reporting those rates back to services in the next month. Yeah.
That's great.
So.
Thank you. So Grant's going on to do a second presentation for us today on behalf of his colleague, Chris Lambeth. I don't have much information about Chris. I'm sure Grant will tell us about it, but he's going to be talking about breast screen participation rates in mental health consumers.
Fantastic.
Very important area.
So, and look, yes, apologies for a marathon session of me speaking, sorry. So look, Chris Lambeth is a biostats trainee in the New South Wales Ministry of Health Biostats training program. Like everyone else who submitted abstracts, it seems a long time ago that we put them in, and so people have moved on from positions. But I'm presenting work that Chris did. And again, would like to acknowledge the traditional owners of the land that we're meeting on. And in this study, we're looking at women who use New South Wales breast screen services. So in this prevention theme, breast cancer is obviously a really important topic. It's sadly the most common cancer in Australian women, with more than 3,000 deaths per year. But there have been really big advances in care and outcomes in the last few decades, and screening's been a big part of that. So Australia's had a breast screen program targeting women in that 50 to 74 age group since the mid-1990s. And there's good evidence that it works, that screening halves mortality in people who are screened, and one death is averted for each 500 people screened. But have women who are living with mental health conditions benefited from these gains? There's certainly reasons to be concerned that they may not have. So there's some European and US studies that find much lower rates of screening. But the evidence is actually surprisingly limited. There's not many big population studies. We couldn't find any study that looked at screening rates and adjusted for things like disadvantage or cultural background or rural-urban location, which can all affect screening rates. And we couldn't find any Australian data. We do know that health system factors are one of the things that drive screening rates, accessibility and cost and things like that. So we can't just take American data and assume it's the same, even though we fear it might be. And there is some good Australian data and New South Wales data that shows that a number of groups of women do have lower screening rates: Aboriginal and Torres Strait Islander women, women from non-English speaking backgrounds, or living in disadvantaged areas. So we really wanted, in order to be able to help drive change and monitor change, to get some local data. So this is another part of this Living Longer program, data linkage program. In this data, we're looking at hospital and community mental health care to define people who've had mental health care, and then we're linking that to Breast Screen New South Wales data and to the New South Wales Cancer Register. So we started with the breast screen data, and we identified all women in New South Wales aged 50 to 74 who had at least one screening mammogram. There are a small number of screening mammograms that are done privately, that are not part of the breast screen program, and we don't have data on them. So we looked at a 2-year period, because 2 years is the time frame within which screening is recommended, and identified about 500,000 women in that age group. And then, a bit like the previous study, we then split that group as to whether people have had recent mental health service contact, and it's the same definitions as before: public and private hospitals and community mental health teams. And in this age group, this is around 33,000 women, of whom about 10,000 had had a mammogram. And so then, comparing those groups, we're able to calculate rates and standardised rates for the two groups. And what we found, sadly confirms the reason to be concerned. So that amongst women who'd had recent contact with mental health services, only 30% had been screened, compared to 53% of the New South Wales population of the same age. So that's an incident rate ratio, the 30% divided by the 53% of 0.57. Or putting it another way, people were 43% less likely to have had screening than other women of the same age. So a really big gap. But it's important to then think, well, why is there such a gap? And are there other explanations for the gap? We do know that mental health service users, even within that 50 to 74-year age group, are more at the younger end, and also much more likely to live in rural or disadvantaged areas. So could that explain some of the gap? To do that, there's a couple of approaches. The first is just to look at subgroups. So this is showing you some of the important subgroups across the bottom, so age, remoteness and disadvantage. And this grey line is essentially the New South Wales rate. And you can see that screening rates go up as people get older, so the highest screening rates are in people over 60. And also screening rates are much lower in more disadvantaged areas. So if the differences we're seeing in the mental health group were mainly due to being different, then once we break down those subgroups, the gaps should be less. But in fact, what we found is the gaps were there in every subgroup. So it was pretty consistently low across the board, suggesting it's unlikely to be just explained by differences in age or disadvantage. The other way we've looked at that is by standardising those rates, so doing a statistical adjustment for the rates. So this is that incident rate ratio of 0.57 that you saw before, which is just the simple crude rate. If we adjust it for age, it really effectively doesn't change, 0.58. You can see these confidence intervals overlap, so it means there's really no significant difference there. If we adjust for age and disadvantage, the same. And if we adjust for age and remoteness, it's the same. That shows that simple differences in age and remoteness and disadvantage aren't explaining those screening gaps. So that's a concern. That's a big gap, and that's a lot of people. So just to move on and present quickly some work that we're doing currently to look at, well, can we demonstrate that that's creating a link to more advanced cancer? Now, because in order to be able to have the numbers to look at this, we've had to look at a longer time frame. So we've looked at data in the New South Wales Cancer Register over 10 years and identified any women in that screening age group who've had invasive breast cancer diagnosed. And I should say, in talking about this, I recognise that, talking about breast cancer and the stages of cancer, it touches on, traumatic experiences for many people and their families, and so apologies for breezing through this quickly. So we identified 30,000 women who'd had a diagnosis of breast cancer in that time, of whom around 2% had recent mental health service contact. And as in the other data, the mental health service users were in the younger end of the age range and more likely to live in disadvantaged areas. So what did we find? Well, the first thing is that screening really matters, and this is not new, but that in the overall population, women who'd had no past screening had a much higher risk of regional and particularly of metastatic illness when their cancer was first diagnosed. So underlining the importance of screening. We did find that mental health service users who were diagnosed with cancer were less likely to have had recent breast screening. So you can see that of these women, 49% had had a recent screen, as opposed to 61% of the New South Wales population. And they're also more likely to have regional and metastatic spread. So 11% had metastatic disease and 43% had regional disease, compared to 6% and 35%. But before concluding it's the screening gap that's causing the spread, you still need to look at it a bit closer. And in fact, the relationship is complicated. So what you're seeing here is 3 pairs of columns, and which is on the left you've got women who had no screening at all prior to their cancer diagnosis, in the middle screening but more than 2 years ago, and on the right screening within the last 2 years. So you can see overall they step down from the left to the right. That shows that screening works and is a powerful driver. But you can also see that within each pair the right-hand column is taller, and that's the column for women who've had recent mental health service contacts. That shows that even among people with equivalent levels of screening, mental health service users still had more advanced disease at diagnosis. And we're really just looking at that now to try and understand why is that, because I guess we didn't expect to see quite those differences within screening groups. So we're looking at this through a statistical approach called proportional odds regression. And so to look at, well, what are the predictors? Before we look at mental health, what are the other things that predict the spread? So definitely age plays a big part, although it's complicated. So younger women are more likely to have regional spread, older women are more likely to have metastatic spread. Women who live in more disadvantaged areas or in cities are more likely to have advanced disease. And then after we adjust for those things, women who have mental health service use are still 60% more likely, so this odds ratio of 1.6, so 60% more likely to have advanced disease at diagnosis. So if we now add into the model the screening, so again, if it was all due to screening, you'd expect that 1.6 would come down to about 1, which would mean no difference in risk. But in fact it doesn't. It does adjust slightly, but what we find is after you also adjust for breast screen, participation, it only reduces the risk to about 50%. So in other words, even after you adjust for all of these factors and screening, women who use mental health services are still 50% more likely to present with advanced disease. And so I think that's something that we need to kind of think about, well, how do we identify what are the other factors going on there? So just to quickly finish up, there's two different studies we've talked about here that relate to each other. The first was that breast screen data, and we showed much lower rates of screening, 30% as opposed to 53%. The second is this preliminary work we're doing looking at whether that leads to more advanced cancer at diagnosis, and the answer seems to be yes, it does, but it doesn't explain it all, and there must be other factors at work as well. So again, finishing on, well, what does that mean for us in terms of the equally well type agenda? That again, this is an area where action is possible. You know, it's a really important area. Screening is something that can be implemented. If we go back to that figure of 500 people screened to avert one death, you can imagine, it's not hard to picture getting 500 people screened, 5,000 people screened, even 50,000 people screened. That can really produce benefits that are substantial. So the first thing for us, I think, is really, it's a complex area, and to make change in something like this isn't something that a mental health service or, a data area or a policy area can act on its own. It needs alliances, it needs action across a range of things. Certainly one of the things we've been very heartened by, our Cancer Institute New South Wales have been very interested in and very supportive of this work. Identifying higher risk groups is a big part of their strategic plan, and so this really does align very closely with the kind of priority of a lot of the cancer policy around the country. But clearly coordinated efforts are needed across a whole range of issues there. We need to keep building better data and understanding. So definitely ongoing data and reporting on screening rates. It is challenging. Screening data is, that's available even to us within the ministry is quite slow. It's quite, you haven't got last year's. There's a long lags. So it does make it easy to gain awareness, but hard to monitor. And we need to understand, again, the many barriers that are there. There have been some interesting studies done looking at people's experience and what are the things that make a difference to them. And there needs to be models developed which are really flexible and local and suit individual communities and groups. We're working with some groups at the moment trying to see how that might work, so we can try and address some of those barriers. So, look, I'll finish again just by acknowledging the colleagues, Chris Lambeth, who really do a fantastic job in his time with us in pulling all of this data together, and also particularly to acknowledge David Currow, who was the Chief Executive of Cancer Institute New South Wales, who's a co-investigator on the study and has really been a great supporter of trying to target, improve these kind of issues and understand these issues better. So, thank you.
Thank you. Two really fascinating presentations, but both highlighting areas that can't hide behind the data. It's there. Does anyone have any questions for Chris?
I do. My previous job
That's all right.
I imagine that for people with trauma histories, it would be quite distressing to get a breastfeed.
Yes.
And would relate to lower breastfeeding. Is that something you found? And have you seen if there's any trauma-informed approaches coming up?
Yeah, I think that's a really important point, and about potential role of trauma. Look, I'm sure you're right. I'm sure that is a factor. We haven't really been able to look at that because we're kind of looking at this kind of in that Google Earth. Here's the whole state kind of view. I absolutely think that there needs to be some work looking at some of that. Cathy Owen in ACT, nearly 20 years ago, I think, did a really good study where they did a really detailed set of qualitative interviews with people and looking at their barriers to participating in breast screening, and certainly trauma came up, and how do you have models that are sensitive and appropriate. There was a really interesting study done, or interesting initiative in Victoria called Wrapped with Care, which was about Aboriginal communities and women sort of making shawls that other women could use to sort of, in a sense, wrap them and kind of support them during the screening process. I think it's those kind of creative explorations and service models that are likely to make a difference. And yes, I think what we're trying to do at that kind of big data level is create the awareness and then try and prompt, and would love to work with partner organisations that would develop models like that and roll them out.
On that note, at a big data level, certainly it's great to hear that 1 in 500 women screened their life is safe, but there is also data that maybe 10 women were screened, are told they're positive, but they're not, and they're at harm, and again that could have consequences for people who have already got serious mental health issues. They could actually be made worse by screening. I'm just wondering, do you have any data about the false positives and whether that's what the rates are in different population groups?
Look, it's a very good point. We haven't looked at that data, but I'll going to go make a note now and do so, because that's, I mean, there is that. There has always been that debate about, harms versus benefits in screening and false positive rates. I mean, my understanding of the reason the national guidelines are as they are with, 50 to 74 is partly that's the evidence that's where that balance works best. So I guess, it's an important point you make, that the personal impacts of a false positive could be, even harder. I mean, I think...
It's not a case not to do it, but
yes.
Maybe we're making sure that there are better supports for people who have false positives.
Absolutely.
You just get a letter saying, we're going to have to do more tests.
Yeah.
No,
Yep.
that can be quite confronting.
That's a really important point. Thank you. And and look, I will. We can have a look at that. I'll have to think about how we could identify false positives in the data set. You've got me thinking about that now. Okay.
But I was picking it up, I always wonder the bowel screening measures as well, that they can just say it was picked up, you had a positive test.
Go and have a colonoscopy.
And how they,
There are people who say, I don't want to have a colonoscopy, I don't care because it's so traumatic having a colonoscopy. It's just adds to the complexity.
It's kind of trying to manage both of those things, being more proactive with monitoring and screening, but actually managing the potential harm as well.
Yeah. That's a very important point.
Did anyone else have any other questions for Grant?
Yes.
Can you tell me how they decide the upper limit age limit for stopping? Or they don't stop stopping the program for screenings?
Yeah. Look, I don't know whether I mean, I think.
It's a hard benefit.
Yeah.
The age has gotten older as time's gone on and treatments have gotten better, but it is an age. It's a encounter's decision.
Yeah. I mean, look, there is some, it's still available. I think it's not that you're not eligible for the screening. So, in fact, there is data on, we've got some data in the data set on women under 50 and over 75, and you can still get free screening over 75. It's just that the target for really promoting it actively by the overall breast screening program is that 50 to 75 age group.
If there's no more questions, join me in thanking Grant for both his